Well, it's a great pleasure to welcome you all here. As Sam said, I'm the director of the MRC LEC here at the university, and I also work as a consultant rheumatologist at the hospital. So it's a great pleasure to welcome you to this session in which we're going to discuss the world-class research on ageing that we undertake between the university and the NHS Trust here in Southampton. Thank you for joining us, and I hope that you enjoy hearing about the discoveries we're making across the NHS Trust and the university through our institutions such as the MRC Life Course Epidemiology Centre, the NIHR Southampton Biomedical Research Centre, and the Institute of Developmental Sciences, all linked within the School of Human Development and Health. These discoveries will help us to understand how to achieve healthy ageing and thus to improve health across the life course in generations to come. So I'm going to move to share some slides. So are you set up for me to do that, Sam? There we go. Wonderful. Right. So I'm just going to make a very quick introduction to the evening. And we're addressing healthy ageing. Now, one of the things that we can definitely say about populations around the world is that they are getting older. We're in the UN Decade of Healthy Ageing. And the WHO has a mandate, so the World Health Organization has a mandate to track progress over this decade. And as you can see from the charts at the bottom, that purple and green age bands for 60 plus and 80 plus is increasing in coming decades across the 4 exemplar parts of the world, but across the whole world. And we know that populations that are aging are going to get more disease because there's so many illnesses associated with older age. And one of the key problems that we face is that although we're living longer, we're not living healthier. And on average, around the last 10 to 20 years of somebody's life will be spent in ill health. And so we need to find ways to understand disease and to intervene across the life course to enable people to live longer but healthier. And that's the key challenge that we face. So I'm going to start by telling you about some of our work in bone health, and then we're going to hear from a wide range of speakers across many different facets of healthy ageing. It's going to be a pretty pacey exploration of the areas, but please do interact with the Q&A function on Town Hall to put your questions in, and we'll do our best to discuss and answer those at the end. So if we think about bone and muscle health, then we can look at this across the life course, and essentially bone and muscles develop through intrauterine life, so in the womb, through childhood, getting bigger and stronger until they reach a sort of maximum size and strength in adulthood. And there's some maintenance, and of course you can maintain that better or worse depending upon what sort of exercise and lifestyle you do. But then, as with many things in life, it's all downhill thereafter. And that might eventually lead to diseases such as osteoporosis, which is thinner, weaker bones, which break easily, or sarcopenia, which is age-related excess loss of muscle mass and function. But through our work at the MRC Life Course Epidemiology Centre and colleagues across the HDH school, we've elucidated understanding of the processes that might determine development of the skeleton and muscles early in life, and then ways of reducing fracture risk in older age. And that's what we're about, reducing the risk of breaking a bone in older age. And I'll tell you first just a little snippet about our work at the start of the life course. So this is about how we can optimize things during pregnancy for the baby. So intervening in the mother during pregnancy to help the baby and then the growing child's skeleton. So the Mavidos trial, which was originally conceived, as it were, by Professor Cyrus Cooper, who was my predecessor as director of the MRC LEC, and led by me in its first phases, and now taken forward by Rebecca Moon and Beth Curtis, that you can see pictured here. And essentially based on existing data from our previous studies, we asked whether if we give women extra vitamin D in pregnancy, will this improve their children's bone mineral and body composition? So essentially, will it make their skeleton stronger and their muscles better? We gave 1,000 units of vitamin D a day from 14 weeks of pregnancy until delivery of the baby. That's the sort of dose that you might have in older age to help with osteoporosis medications, or a matched placebo. And what we found was essentially that at birth and then at 4 years and at 6 to 7 years, bones were stronger and more dense in the babies and in the children of those mothers who were randomized to vitamin D. And working with colleagues at the Institute of Developmental Sciences, as pictured there, we've been able to elucidate some of the mechanisms relating to the placental function, relating to gene signals, which might underlie these effects. And these findings have influenced policy across the UK and worldwide. And we're currently in the Action Medical Research funded follow-up at 11 to 14 years. So just very briefly, at the older age of the life course, we're about trying to prevent osteoporotic fractures, which are a major source of ill health, morbidity, with disability around that, similar to chronic lung disease, lung cancer, or dementia, and a major hit on health, costing the UK about £5 billion a year. Through our work with the International Osteoporosis Foundation, of which I'm now the president, we've identified key gaps in the treatment of osteoporosis, and that's across case finding and management, public awareness, and government and health system issues. And only about 30% of individuals at high fracture risk are appropriately assessed and treated. We have very good ways of doing this through a tool called FRAX, which is available in the UK and across 100 or so guidelines internationally, and has around 3 million visits a year. And this allows us to assess the probability of a fracture. I'm part of the FRAX group. We're now developing FRAX 2. This is linked to our national guidance from the National Osteoporosis Guideline Group and provides a very easy way to assess fracture risk. And we've demonstrated that screening for high fracture risk in a trial of 11,000 women, in which we co-led with Sheffield and Norwich, reduces hip fracture risk by 28%. And now, in work led by Beth Curtis in the LEC and Eugene McCluskey, who's a colleague in Sheffield, working with the International Osteoporosis Foundation and the Royal Osteoporosis Society through the UK All-Party Parliamentary Group on Bone Health, we're now exploring a new study with the BRC, the Biomedical Research Centre here in Southampton, to understand how we can implement this screening for high fracture risk in the population in primary care. If we can achieve this, it will be game-changing and help us to close that massive undertreatment, to make sure that every individual at high fracture risk is appropriately assessed and treated. So in conclusion, osteoporotic fractures are a leading health burden globally. We can assess that risk and intervene across all of life. And ultimately, novel interventions and screening for high fracture risk in older age will revolutionise the approach. So with that, I'm going to hand back to Sam to share his screen. And whilst he does that, I'm going to introduce our next speaker, who is Dr. Mark Burton, who's a Senior Research Fellow in the Epigenetics Group at the School of Human Development and Health at the University of Southampton. And his work really focuses on the molecular biology of muscle health. And he's going to tell us about sarcopenia, which is excess loss of muscle strength and function with age. And he's going to tell us about the underlying mechanisms and how that might inform new approaches to intervention. So Mark, without further ado, over to you.
Hi, so my name's Dr. Mark Burton. I'm going to be talking to you today about aging and skeletal muscle decline. And I'm a Senior Research Fellow in the HDH Research Group, and I'm sponsored at the moment through the BRC, through an NIHR's Biomedical Research Centre Bridging Fellowship. So as we age, our muscles change. So we lose muscle strength, size, and function. But in a subset of individuals, this loss is more rapid, it's more severe, and it results in increased frailty, falls, and early death. And this is known as sarcopenia. And sarcopenia prevalence affects between 5 and 15% of 60 to 70-year-olds, and up to 50% of those over 80, which equates to 2.5 million people in the UK, and an annual cost of approximately 5.7 billion to the NHS. Now, there are no treatments for sarcopenia at present, and the disease is gradually becoming more understood, but it's still relatively difficult to understand exactly what contributes to this. But what we do know is that the main contributors consist of cellular, molecular, genetic, and lifestyle factors. And my research and the research within our group currently focuses on the key causal molecular mechanisms that drive sarcopenia and aging, and how we can target these for effective interventions. So in terms of molecular biology, exactly what do I look at? So the main thing that we look at the moment are genes, which contain codes to make proteins within the body, and these genes which encode for these proteins are essential for human health. And another molecular marker that we look at, small non-coding RNAs, and these are small molecules that regulate levels of genes. And the way we look at these genes and small non-coding RNAs is through a process called transcriptomics, which is a measurement of genes to see how they are turned up or down in different cells and how these changes may contribute towards understanding disease such as sarcopenia. So exactly how do we use transcriptomics in our aging muscle research? Currently, we've got 3 projects underway. One is in understanding the individual cellular contributions to muscle tissue. The second one is looking at small non-coding RNAs in human serum as biomarkers of aging and muscle dysregulation. And the third one is using nutraceuticals to improve aging muscle. And to give you an example, I'm just going to talk about project 1, which is understanding the individual cellular contributions in muscle tissue to sarcopenia. And I'm going to use, for people that like baking, a cake as an example. So here we have a cake. It looks nice, but it tastes a bit funny. And we don't really know what's causing the funny taste. And this equates similar to a process that we use called bulk transcriptomics, which allows us to measure all the genes together, which would represent the cake. And we know that there's a change in the genes, but we don't exactly know where that change is coming from, in which cell population. So to figure this problem out and see where things are going wrong, we need to know the ingredients. And this is exactly what we use single cell transcriptomics for, which allows us to measure individual genes in individual cell populations within tissue, for instance. So it allows us to see the individual ingredients that are in the cake and exactly where the signal is that is going wrong. And from this, we could tell, for instance, using this, then egg is off, and that's what's causing the problem with the cake. We've applied this to muscle tissue using a proof of concept grant awarded through the MyAge Research Network. And we have muscle tissue samples taken from the Hertfordshire Sarcopenia cohort. And we apply single cell transcriptomics to those muscle tissue samples. And from this, we've been able to characterize individual cell populations within the muscle tissue from sarcopenic and healthy muscle taken from older adults. And we've been able to identify changes within specific populations of cells that differ in sarcopenia. So within the diagram, we can see a UMAP on the left with the colored images, which represent cell types. And on the right, we can see a gray UMAP, and you can see there's a red area circled. This represents an increase in gene expression in a specific gene within a sarcopenic sample compared to the grey diagram on the left, where you can see that there isn't the red change. And we can also work out the trajectory of gene expression with cells from each population. This gives us information on the genes, the pathways involved, and how those pathways can be affected. And it also gives us an idea of how we can apply nutraceuticals and different compounds to actually modify these gene changes back to where they should originally be. So just in summary, the research we're doing is identifying novel changes in gene expression linked to sarcopenia. We're using high resolution data analysis to investigate these changes in specific cell populations in muscle. And we're able to test our effects of nutraceuticals in these muscle cells to try and correct these changes. So overall, this is increasing our understanding of muscle aging, and it's leading to development of new intervention strategies to treat the disease.
Great. Thank you very much indeed, Mark. Really nice overview of the muscle works. So we're now going to move to Dr. Harnish Patel, who is an associate professor of geriatric medicine at the University of Southampton and a consultant physician in medicine for older people at the hospital here. Is going to tell us about aspects of care for older people around frailty and health in older age. So Harnish, over to you.
Great. Thanks, Nick. Evening, everyone. Thank you for the introduction. Well, I'm going to talk about frailty. And this term's been used readily across healthcare, but also in the sports world. And lots of sports pundits talk about frailty in terms of defensive frailties of various football clubs, not mentioning any. By doing so, conjuring up images of what frail looks like or what frail means. But let's try and define frailty and what it means for an individual, how it develops, and hopefully what we can do about it. And that's the purpose of this evening. So we'll go on to the next slide and illustrate by this very sort of simplified diagram. So ideally, the healthy aging paradigm is represented by the thick blue line, and starts off with someone quite physiologically robust to someone not physiologically robust. But life's not fair. Frailty, as depicted by the dashed red line, starts off in early life, and it's when someone's physiologically robust, so they've got intact physiological systems across multiple organ systems, and at this phase, for sure, illness and injury can lead to a functional decline. But the key thing here is the recovery is very quick or quicker. But so as we progress in the life course, so as we age, for example, we accumulate various physiological insults that eventually depletes our reserves across multiple physiological systems. So bone, muscle, you've heard about, immune, endocrine, GI tract, skin, and so forth. And what this does is make an individual more physiologically vulnerable. So they're predisposed to functional decline at very minor or minor illnesses or stressors. So that's what meant by physiological vulnerabilities. So what happens when you are stressed, for example, an illness, you get a functional decline, but the key thing here is that the recovery takes longer. So as you can see, as you progress down the life course, increasing age, for example, the ability to recover becomes less or takes longer, but you get more vulnerability and illness, and you accumulate one or more comorbidities that further depletes your physiological reserves. So eventually, you reach a theoretical point called the disability threshold later on in life, where you're so depleted in your physiological reserves that actually the ability to compensate becomes less and less. So your illnesses, your stressors deplete your reserves, and your ability to recover from successive illnesses or stress becomes less until you reach a point B, and that's what we commonly see in hospital, where the ability to recover is less and you're more predisposed to institutionalization, hospitalization, your morbidity increases and your mortality increases. So at various points in the life course, at point A or point B, our shift in intervention or treatment changes. So whereas point A onwards, until that disability threshold, there is margin for intervention. And actually everything we'll hear this evening is geared towards reversing those abnormal states or frailty or physiological reserve. Whereas at point B, maybe our focus should change to a more sort of symptom-directed or a more palliative approach, and that's up for discussion. So next slide, please. So what you can see that the abnormal state of frailty is not only governed by the physical domain you see, but also psychological and social domains. So you can see that amelioration in one of those domains, so physical, for example, is unlikely to ameliorate those abnormal states of frailty unless you deal with the social, psychological, and cognitive. And you can see the risk factors for developing frailty in the bullet points on the right of the screen. So for that, you need an effective, highly trained, skilled workforce. And I as a geriatrician, I'm only as good as the MDT or the multidisciplinary team that I work within. And I'm, as good as my colleagues. So to relieve the abnormal state of frailty, we need not only doctors, nurses, but healthcare assistants, pharmacists to deal with the polypharmacy, social prescribers, health and well-being coaches, but also our research colleagues to find out, what we can do about the abnormal state of frailty. So key points here is how to intervene, and you'll hear a lot about that. So how do we intervene with nutrition, physical activity, the main causes, but also the MDT approach. So I'll end there and welcome to answer any questions at the end.
Fantastic. Thank you very much indeed, Harnish. Really nice presentation. So we now move to Professor Maria Stokes, who's Emeritus Professor of Musculoskeletal Rehabilitation in the School of Health Sciences here at the university, part of the Active Living for Health Research Group. And Maria is going to talk to us about physical activity across the life course for healthy aging. Thank you very much.
Thank you very much, Nick. So, Sam, there's at the bottom there, I just need something to move out of the way. There we go. Thank you. Got it. Okay. Okay, so I'm going to be talking about the importance of physical activity across the life course, and that's in an effort to prevent sarcopenia or and prevent early frailty. So inactivity is a very potent thing, and you can see on this diagram that it causes more deaths per year than smoking. And as the triangle gets smaller down towards the bottom, 10 deaths from shark attacks, if we put as much effort into preventing deaths from some of these other causes as we do into physical inactivity as we do some of these other causes, then I think we might be a bit further on in managing this. And the World Health Organization has published this year that 1.8 billion people are not active enough throughout the world, and they're at risk of ill health. And this has become worse over the last 10 years. So we do have a big problem on our hands. So I don't need to spend time on the benefits of physical activity. We know that it's good for our heart, lung fitness, muscles and joints, and mental health and well-being, and also preventing a lot of these non-communicable diseases such as obesity, diabetes, and heart disease. And there are many other effects of physical activity which we don't have time to go into today. Now, the World Health Organization has come up with some recommendations for the minimum amount of physical activity we should be doing. So for children, they're saying that they need 60 minutes of moderate to vigorous activity every day. And for strengthening the muscles and improving the bone health, activities at least 3 times per week. Now, as we become adults, then that's 150 minutes of moderate activity throughout the week. And there are other combinations of this that you can do, but the muscle strengthening activities need to be 2 or more days a week. Now, over the age of 65, this then becomes, as well as the 150 minutes a week, it's recognizing that people may not be as able as before. So you can do activities of at least 10 minutes, bouts of 10 minutes, and then be as active as possible as the abilities and conditions allow. Now, when mobility is poor, the physical activity needs to enhance balance and prevent falls on 3 or more days a week. They're the guidelines. So if we look at the lifelong activity for healthy aging, this is a little bit like ABCs in your pension. You can buy back years. So for masters athletes who are, working at a very high level all their lives, they can, someone in their 80s can have sort of a biological age of someone in their 60s. And this is Jem Lawson, who's one of our patient and public involvement representatives in the Versus Arthritis Centre for Sport, Exercise and Osteoarthritis. And he's still doing triathletes, and he's living with osteoarthritis and doing incredibly well. Now, we can't all operate at this level, and a lot of people don't want to. So what can we do to keep ourselves healthy? So there is a difference between exercise and physical activity. And if we take exercise on the left first, so that's activities needing physical effort and for health and fitness reasons, and you need to plan the exercise. So this is like going to the gym. A lot of people don't want to do that. Physical activity is any movements that we do during the day that use energy, our muscles. And then the leisure sports, for example, golf, are things that, although they're good for our health and fitness, a lot of people don't do that for that reason. They do it for the social reasons, and they have the benefits of the physical activity. And some work that we've done here in Southampton recently has shown that for those over 65 who play golf for leisure, that they tend to be stronger and have better balance than those who don't play golf. So anyone promoting physical activity in the community, it's very important to ensure that we are, making our messages relevant. And during the COVID-19 pandemic, there was a sort of a divergence in that a lot of people were getting fitter and more active, and people in Black and ethnic minority communities were actually showing that they were less active. And when we did a study on this, that some of the public health messaging people felt wasn't directed at them, or they didn't identify with it. So we got together and co-produced some messages and leaflets with people in those communities. So it's just important that when you are trying to promote physical activity to work closely with people that you're trying to help. So preventing premature frailty, as we've found that it declines with age, function declines with age. And Nick talked about the independence threshold, and rehabilitation can sometimes help, but not always. So the main thing really is trying to prevent some of these things happening. So we mentioned about lifelong physical activity, the strength and balance, preventing falls. And some recent work we've done with astronauts who, in microgravity, their muscles they're floating around, and despite a lot of activity they're doing during the exercise periods, we found that some muscles were not spared. So there may be lessons for us on people who are on long-term bed rest or inactivity. Do we need to be more targeted with our rehabilitation? And just finish with some things that we can do in everyday life. Getting off the bus, stop earlier and walking, and some activities can cause injury. So we put a lot of effort in the Versus Arthritis Centre into preventing injury and osteoarthritis. And a couple of tips of just strength and balance, sit to stand. You can do these while you're boiling the kettle. If you just do that, it's 15 3 times a day, or standing on one leg while you're watching TV or washing up or brushing your teeth. So just things to integrate into everyday life. Thank you.
Fantastic. I feel I should go for a jog now, but maybe I'll leave it till after 8 o'clock. Great, thank you very much, Maria. So now I'd like to invite Dr. Stephen Lim, who's a Principal Clinical Research Fellow and Honorary Consultant Geriatrician in Academic Geriatric Medicine here in Southampton, has a real interest in multimodal interventions to improve muscle health, and is going to talk to us on this theme. So thank you, Stephen, over to you.
Thank you very much, Nick, for the introduction. Good evening to everyone. So, as introduced, I'm a consultant ortho-geriatrician here at Southampton. I look after patients with falls and fragility fracture. The research group here in aging, we're involved in quite a few research studies in the hospital as well as in the community, looking at preventing muscle loss and functional decline. But I'll only be sharing one particular study this evening. So let me just take control of the slides and then I'll start sharing. I can't seem to see the scroll button down below.
Okay, so it's right in the bottom left.
Yeah, it was there before. It's not there. I'm going to try and take control again.
That happened to me as well, Stephen. If you just click on where it says Samuel Dalton, it should come up.
Oh, there you are. Brilliant. Okay, so Dr. Patel has shared a lot about frailty, and so we know that essentially it is about, firstly we say that patients don't like to be called frail, and sadly there's a lack of good words we can use to describe frailty, but essentially it is multiple causes ultimately resulting in someone being vulnerable to being dependent or higher mortality. But on the flip side of frailty is the concept of being resilient, and it really, as clinicians, healthcare professionals, researchers, what we want to be doing is to consider how we can support people, older adults living with frailty, to be more resilient, to be able to bounce back from a stressor. As mentioned, you can see here in the green line here's someone who is quite robust and not frail. And when the stress events happen, say, for example, a pneumonia, they still remain quite independent and they recover fairly quickly and back to their baseline. As opposed to someone living with frailty, they have a significant decline, being dependent, and they take a long while to recover, and they don't often go back to their baseline. We've talked about what frailty is. You have, in terms of what determines, the trajectory of someone being frail, you have the genes, the genetic factors. That's what you've been dealt with, really. And then you have the environmental factors that through mechanisms that will ultimately result in how your genes express itself, and through various different, say, for example, environmental factors such as smoking, air pollution, it could be your diet, and then things like that, ultimately resulting in cell damage, and so that your bodily function, like your brain, your immune system, your muscle, your heart, your kidney, and your lung, their function begins to decline, and then that results in frailty. But several key factors that can intervene or prevent that frailty slope to go really steep and to flatten that slope that you see in the slide shown by Harnish is physical activity and nutrition. And with the aim that if we intervene, if we looked after the environmental factors to reduce this insult to your bodily function, and then we increase physical activity and nutrition, hopefully when a stressor happens, then there's less result in falls, delirium, and resulting in increased care needs, hospital admission or care home admission. So why is it important to identify frailty? Firstly, if you don't identify, you won't intervene. Now, we know that patients who are living with frailty have an increased risk of death following surgery. They are also at higher risk of complications if they come into hospital with longer stay. They become more dependent with their activities of daily living, poorer quality of life. In a study that was done and in collaboration with some researchers in Europe, we looked at least 60 hospitals across Europe, and among older adults who came into the emergency department, at least 40% of them, those aged 65 and above, live with at least a degree of frailty. So it is very, very common. Now, here at Southampton Hospital, now this is a study funded by the University Hospital Southampton, and it's just one example of how we're tackling this. It's a feasibility study. In other words, we're thinking, can we do this? Is this concept doable? Can we train volunteers to engage with older adults discharged from hospital to eat well and to stay active? And so what we did was patients who come into hospital, we would recruit them to participate in a 12-week intervention of exercise and nutrition, either through Zoom or through telephone. And across a 12-week period, first 4 weeks, they will have 3 sessions, next 4 weeks, 2 sessions, and then the final 4 weeks, 1 session. And the idea is that as we step back, they continue to do the activities. And the participants were also given exercise booklets and an exercise video to help them to engage with the exercises when these sessions are not going on. In terms of the nutrition support, these are hospital volunteers who are trained by us. They work with participants to review their diet using this thing called the nutrition wheel, and is a tool that is used to aid conversation about malnutrition, and it will help signpost people to good and health balanced diet. The volunteers are also were also trained to and receive behavior change support based on the making every contact count principle. So the idea is that not only do we give the intervention over the 12-week period, but what we really want to see is that they continue that after we sort of step back once the intervention concludes. So we were able to train 5 volunteers and 17 participants completed the intervention. Our participants were all in their mid to late 80s, and they were living with moderate frailty. So all of them needed help with activities of daily living. So we're looking at a very frail group of patients, but the attendance to the group sessions was really good. It's about 75%. And among these groups of patients, we were able to see improvement in activity levels. This is measured using some fancy watches, but also with questionnaires. And they also had improved appetite and quality of life at 3 and 6 months. And we also interviewed these patients and their carers, and the online group was perceived to be a positive vicarious experience, and the telephone calls provided reassurance and monitoring to socially isolated older adults. In terms of some of the barriers, there was, for those who didn't engage as fully, there was lack of confidence and fear of falls. These are exercises they're what we call resistance exercises, using stretch bands or TheraBands to try and improve their muscle strength. Those who were living alone or had lack of support were also at a higher risk of dropout, and other things such as physical pain and limitation, lack of motivation and fatigue also prevented them from engaging fully. Now, frailty, as Hanish has mentioned, is multidimensional, and exercise is only a cog in one of the in the wheel. The key management for frailty is what we call comprehensive assessment or comprehensive geriatric assessment, which includes physical assessment, socioeconomic factors, their function, their mobility, psychological and mental function, and medication review. And that thorough assessment allows us to create a problem list to then develop a personalized care plan to intervene and regularly review. So, in closing, exercise and nutrition is really important, and initial engagement is key. For patients and older adults who are keen to prevent falls, strength and resistance exercise and balance exercise are really important. The literature suggests up to 3 times per week. In terms of intensity, it has to be moderate intensity. That means you have to feel the strain on your muscles to really get that benefit. If it's too easy, you're not really going to get that benefit. You've got to. It's important to set goals to know what your patient wants, and also ultimately behavior change is really, really important, and social engagement is an important aspect. So I'll leave that there, and thank you very much for staying tuned.
Thank you very much, Stephen. So we're going to, I'd like to invite now Professor Philip Calder, who's Head of Human Development and Health and Professor of Nutritional Immunology here at the University of Southampton. And Professor Calder is going to outline some nutritional strategies to help mitigate age-related immune decline. So Philip, over to you.
Yeah, thanks so much, Nick, and thanks for inviting me to be part of this really exciting evening. So we've heard a lot about musculoskeletal changes over the life course. I'm going to change tack now and talk about immune decline, but actually the patterns of what's going on are quite similar. So the starting point, of course, is that we need our immune system to help defend us against harmful organisms in the environment, particularly microorganisms, bacteria and viruses, and so on. And if our immune system is working well, we have a good chance of dealing with these pathogens and remaining infection-free, or with low-level infections that we can deal with just fine. Now, our immune system develops early in life, but that's not the focus for tonight. But unfortunately, it can decline as we age. And this is so well recognized now that it's given the special name immunosenescence. In other words, the immune system going to sleep. This pattern of age-related decline actually is following exactly what you've heard about for both bone and muscle. So I think of this immune decline with aging as sort of something silent or invisible that we can't see, but which is probably tracking exactly what we can see with bone and muscle. So older people can have weakened immune systems, so they're more at risk of infections and infectious illness, more hospitalizations related to infection, more complications, perhaps poor wound healing during hospitalization, longer hospital stay, greater use of antibiotics, and of course also poor responses to vaccination, and ultimately greater risk of mortality. Although the immune system is declining with age, alongside immunosenescence, many older people show a state of heightened low-grade inflammation. And again, this is given a particular name, which is inflammaging. inflammation associated with aging. And we now know that inflammation is important because it increases the risk of many of the common non-communicable diseases of aging, including cardiovascular disease, metabolic disease, cognitive decline, the altered body composition that we've been hearing about, loss of lean mass, for example, resulting firstly in sarcopenia and then later on in frailty, immune decline, and many cancers. So the age-related changes in the immune system increase risk of both communicable diseases, that is infections, and non-communicable diseases. So what's going on here really is an imbalance where we haven't got enough of the protective aspects of the immune system and we have too much of the pro-inflammatory damaging aspects of the immune system. Now, an important player in this change could be our gut microbiota, because we know the bacteria living in our gut lumen, particularly in our large intestine or colon, interact with our gut wall, but also with our immune system. And in humans, about 70% of our immune system is associated with our gut wall. So this is a really important part of the body for interaction between the environment, that is the gut lumen with all these bacteria, and the immune system. And we know that actually our gut microbiota influences our immunity and our inflammatory tone, but also our immune system is keeping our gut microbiota in check. So this is a sort of a bi-directional series of interactions here. Now, I talked about the immune system changing with age. I talked about inflammation changing with age, but our gut microbiota also changes with age. This could be due to changes in diet, to medication use, to illness, and so on. Also decreased physical activity. So we think maybe this changes in microbiota, immunity, and inflammation are all linked to one another. But of course, we don't know which one is really coming first, but we think they're linked with one another. Now, I'm very interested in nutritional strategies that can prevent age-related immune decline and help to recover healthy immunity. And here I sort of summarize strategies that have been used that are important. So we could target the immune system and inflammation directly through good nutrition, delivering sufficient amounts of vitamins and minerals, including vitamin D that you heard about for bone health. That's also very important for immune health. Other essential nutrients like essential amino acids, essential fatty acids, and other things as well. We can also target gut microbiota through fiber, through prebiotics, and through probiotics. So we could target microbiota to improve immunity. We could target immunity to try also to improve gut microbiota. So these are the things that we use in our experimental studies in humans, and we also undertake research to try to understand the mechanisms by which these nutritional interventions are helping to support immunity, control inflammation, and influence the gut microbiota. So just to finish, I want to flag up two studies which we just finished in the latter part of 2024 that will be producing their data and publications going into 2025. These were two intervention studies in older people. The first one was looking at the effects of vitamin D alone, a probiotic supplement alone, or the combination of vitamin D and probiotics, with the outcomes being markers of immunity, markers of inflammation, and gut microbiota. So I think this is an exciting novel study to be looking out for next year. And then our second one was targeting gut microbiota specifically with a particular fiber, soluble corn fiber, again looking at markers of immunity, inflammation, and gut microbiota. And again, this study is carried out in older people. So I think we have two studies just completed that will be generating exciting data, maybe to come back and talk about later next year. So just to summarize, in common with the other physiological systems that you've been hearing about, aging is often associated with a decline in immunity, which increases risk of infection and impairs response to vaccination. Aging is also associated with an increase in low-grade inflammation, which increases risk of non-communicable diseases. There's a link between our gut microbiota, immunity, and inflammation, and microbiota is also changing with age. And in our research, our human trials, we test interventions in older people to see whether we can improve gut microbiota and immunity and normalize inflammation. Thanks very much for listening.
Thank you very much, Philip. So finally, we're at our last talk. So I invite Professor Elaine Dennison, who's Professor of Musculoskeletal Epidemiology at the MRC Life Course Epidemiology Centre, to talk to us about research in one of the cohorts, the Hertfordshire cohort that we host related to loneliness and COVID-19. So Elaine, over to you. Thank you.
Thanks, Nick, and good evening, everyone. I'll keep this presentation fairly brief so we've got some time to answer some of your questions. And I'm going to move quickly on to the next slide because there's actually a spoiler alert in my title. So just by way of background, I'm going to change tack completely, really, and talk about social isolation and loneliness in older people. Obviously, this is something that can affect people at any stage in the life course, but we do recognise that it's a particular problem in later life. We hypothesised that possibly reduced mobility, so linked to poor musculoskeletal health, so problems with your muscles, your joints, your bones, might actually make someone more likely to be socially isolated and lonely, because we thought if they had painful joints, they might not be able to get out and about so much. And we tested this in a study that we did in Hertfordshire, which was actually conducted during the COVID-19 pandemic. Next slide, please. So as Nick said, I work largely with the Hertfordshire cohort study, and this is a cohort of 3,000 men and women born in Hertfordshire between 1931 and 1939 and still living there. And at the time that we conducted this research, we were actually doing some work with just over 150 cohort members who at that time were aged, median age of 83 years, and who'd been helping us with this study when COVID hit. So we chose to actually adapt our study protocol a little bit. We asked some extra questions to try and incorporate this hypothesis. So I'm an epidemiologist. We love questionnaires. So there are quite a few relevant questionnaires that look at someone's social isolation and loneliness. And we took the opportunity to incorporate these. We asked a lot about their lifestyle and their living arrangements. And then when we went back for the follow-up phase of our study, we went back and asked them again about social isolation and loneliness. Next slide, please. So these are the headline findings that we found. So being married was protective against both social isolation and loneliness. Probably people won't be surprised to hear that. Participants who reported being lonely tended to drink more alcohol, but importantly, we didn't see any association between problems with someone's muscles or joints or bones and them being socially isolated or lonely. We didn't see any association at all. But perhaps the most striking finding was the remark about self-efficacy. So we'd asked some questions to gauge someone's self-efficacy in the questionnaires that we'd administered to people. And we found that having higher self-efficacy was highly protective against someone being either socially isolated or lonely. Next slide, please. So you might think, well, what is self-efficacy exactly? And this is the definition that you see at the top. So broadly speaking, it's a person's particular set of beliefs that determine how well one can execute a plan of action in prospective situations, or put more simply, and this is, I think, much more straightforward, it's a person's belief in their ability to succeed in a particular situation. So you might think from that, well, how amenable is that to change? Is that something that is just part of your personality and your makeup? Next slide, please. Well, in fact, it turns out that actually you can influence someone's self-efficacy. There are training techniques that you can use to actually improve self-efficacy throughout the life course, including in older adults. So this was a really interesting finding, because it suggested that actually we have autonomy over some of these things. Next slide, please. So I'm just going to conclude with a few comments. So just to reinforce, we didn't see any link between problems with muscles or joints or bones in this population with social isolation or loneliness, but we did see strong associations with self-efficacy. Clearly, this was quite a small study, and it's obviously important to actually do follow-up work in larger populations that actually follow people up over a longer period of time to actually assess this in greater detail. But I'm going to close there and let Nick get on with answering some of our questions, hopefully. Thank you.
Thanks very much, Elaine. And I don't think I'm going to personally answer them all. I might spread them around the panel a bit. Great. So if we can have all the speakers back on again, that would be great. I'll try and enlarge my screen rather than log off. So we have time for some questions and hopefully answers. We've had some pre-submitted. There's one or two come through during the presentations. I think a good place to start is quite a fundamental question of what is healthy aging? And I mean, to me, that it's clearly a difficult question to answer with specificity, but I think it raises questions about how we look at aging and what sort of measures we might judge it by. So, yeah, are we thinking about function? Is it about how people can carry on doing the things they want to do? Their health needs to be good enough for those activities of daily living. Is it about things we can measure and describe? Is it about the complete absence of disease? Is it about molecular mechanisms? So does anyone want to dive in with any thoughts on that? So Philip, yes, please.
Yeah, I think it's a great question. It's a simple question and a difficult question at the same time, Nick. So I think it's probably all of the things you mentioned, because they're all interlinked with one another. So for me, it's sort of maintenance of more optimal physiology, and resilience to challenge, whatever the challenge might be. And it might be an infectious challenge, it might be an ability challenge, whatever. And of course that requires molecular mechanisms to remain active, so we can function well in our environment. And it enables things that we can measure either clinically or experimentally. So I think all those things are related to one another.
Thank you. And how much, Harnish, you've also got a comment, but how much do you, Philip and you, Harnish, think that it's about maintaining a sort of level versus maintaining resilience and ability to get back to where you were before? Is it a mixture of both? Do you want to quickly come in on that, Philip, and then hand to Harnish?
Yeah, I think it's a mixture of both. And I think the figures that the muscle and bone people showed suggest that it's bringing you back towards where you might have been, a decade or two earlier.
Yeah, Harnish. Oh, you're muted.
Yeah, of course, yes, I completely agree. It's the healthy aging is a subjective feeling based on the individual's personal, social, physical, psychological circumstance and how well they cope with their interacting comorbidities and what it means for them. The important point about frailty is not synonymous with aging. Not all older people are frail. Yeah, most of them are living in the community really healthy. I mean, we get a skewed view in hospital because we see the burden of frailty, but really important that actually healthy aging is defined by these individuals living quite independently in the community, enjoying their lives. So, let's not get a skewed view of frailty. Of course, it's important, and of course, we should be geared up to intervene through all our interventions that we mentioned.
Yeah, thank you. And I think that leads nicely into the next question, which is really setting out that, of course, that we know there's things we can do to prevent illness in older age, and we talked about physical activity, nutrition, and so forth. But they're often talked about in terms of secondary care and research and rather specialist situations. But I think the question is really asking about how that work and those preventive activities could be left shifted into the community and primary care. And I don't know whether, Stephen, you want to comment on that from your geriatrician perspective.
Yes, sure. So there are, our research group is currently engaged in working with, for example, Brandon Care, to train volunteers in the community who are leading community clubs to encourage older adults to engage in resistance exercise and to improve nutrition. And certainly through the NIHR Applied Research Collaboration, so I lead the Aging and Dementia theme, we really welcome collaboration with our community partners and our community organizations to work together. And particularly we've got a huge focus on our underserved communities, those in rural, coastal area, or those with high disease burden, to be able to work with community leaders to try and spread the gospel, if you like, of physical activity and nutrition, and to make sure that people are engaged in healthy living that will work towards promoting healthy aging.
That's great. Harnish.
Sorry, Megan. Absolutely. Let's not forget our primary care teams, and actually they're really well placed in amongst their big practices with social prescribers, health and wellbeing coaches, pharmacists, as well as the GPs. And actually, the more we can do to break down those arbitrary barriers between primary and secondary care, I think the better we can deal with our population, because their problems are the same as ours, and ours are the same as theirs. So, let's not have this arbitrary primary secondary care barrier.
Yeah, couldn't agree more. So, and Maria.
Yes, and just I think thinking about earlier on about prevention, I think we can go and talk about education and education of school children. They're doing quite well with nutrition, but it's really teaching them about, why they need to be physically active. They do PE, but they need to know why they do it, and try and encourage them to keep doing that when they leave school and as they get older.
And I suppose that leads to another question of how much all of this is a medical problem versus a sort of societal and environmental problem. And I mean, Elaine, you've talked about loneliness. Do you have other thoughts on the role of sort of the social context and the environment on healthy living in older age?
Yeah, thank you. Yeah, I mean, I think it plays a huge role. So clearly the barriers are more than just physical barriers, but we know that the environment, the neighbourhood facilities also are very, very important to access for older people and to their experience. We've done quite a lot in Hertfordshire looking at actually mapping some of the neighbourhood features to older people's experiences and quality of life. So I think actually this is a multidisciplinary research agenda, isn't it? I mean, that's what we're seeing. We need to be working across all the disciplines, even as far as sort of town planning and things like that. We're not going to fix this alone. We need to be working across the whole gamut. And I think it's fantastic that Southampton has got such an interdisciplinary research field, because that, I think, is how we're going to see the really big advances. And with the demographic changes in our population, I think the time is now. It's really urgent that we're taking this forward.
Great, thank you. So I think we've got time for one final quick question, and there was a question relating to genetics. So Mark, just very briefly, is there evidence that we can do anything with genes to help healthy aging?
I think the question linked to genes is really, really interesting, and it's something that is great in terms of our research to get across a strong message that although our genetics, doesn't change, our epigenetics, which is the way that our genes are turned on and off, can change through the life course. And this is influenced by environmental factors specifically. So the things that we've previously talked about, nutrition, healthy lifestyles, exercise, socializing, all of these things can affect the epigenome, which can modify gene expression through these epigenetic mechanisms, and can actually help to combat kind of negative effects of disease. So we can, by putting in positive things in our lives and healthy things, we can all work towards maintaining our health and effectively combating disease in that way. So
thank you. Well, that's a positive note on which to draw things to a close. So I think we've really heard fantastic multidisciplinary research across the life course, and we've heard how there are things we can do to maintain health into older age. I think most of us know what we should be doing, probably going for a jog after this, except we don't, so we probably need to do more of it. There's an awful lot that can be done by linking things up across sectors. We've heard about that the need to look at things across primary and secondary care and across different research modalities. And we really need to think about these issues, not just in terms of health, but in terms of social care, social environment, the wider environment. And that brings in, of course, government and policymakers and funders and so forth. So I think a lot of hope, a lot of opportunity, fantastic research that's being undertaken here. Thank you very much to all the speakers. Thank you to all of you for your attention. Thank you for the questions. Thank you to Sam, Hannah and John and the team for pulling it all together. Do join for the next one of these, and thank you very much and enjoy the rest of your evening.
Thank you. Thanks, Nick.
Thank you.